we will ask Perry, who is nurse practitioner, as we heard, dealing a lot of time with patients with inherited arrhythmia, to speak about her clinical management and some perspective from her point of view.
Let me just open this one.
Mhm.
Okay, thanks. Thank you, Dr. Zariba. Appreciate the time and invitation to come and be a part of this seminar. Kind of made me reminisce of the days that being in clinic with Dr. Moss, because I'm not as young as Bonnie and Chris. So I do remember those days of being in clinic and at the time not really appreciating as I was filling out information with, EKG data and those specific clinical points that, it was going to translate, 30, 40 years from now into clinical guidelines as they have, which is a pretty remarkable thing for me. So I have the pleasure of working with many patients in the electrophysiology clinic with long QT. And over the years, many advances in both science and genetic testing has really contributed to a better understanding of our medical management for these patients. Initially, a lot of the genetic testing that was done was really based on research studies. So people would send off blood work and it would be months or years before they would hear anything. Whereas now we're, having commercial testing, which has been, a huge attribute in helping to care for these patients. So one of the key things is that it really does take a multidisciplinary team approach to enhance the care of LTP patients and families, physicians, researchers, genetic counselors, technicians, both medical and device genetic testing. And as we need more, from the psychological standpoint for support for patients. Their presentation of folks are very different. Some come in with sudden cardiac arrest. Others have no symptoms whatsoever. They may have had some EKG changes. So it's really important that we take very good history in the clinical presentation to really differentiate what are the causes of a person passing out. Is it a true faint or is it seizure activity? And syncope and seizure are really red flags in our world for something that might be, more sinister that needs further investigation. And so to that point, there can be possible overdiagnosis is one paper, and looking back, seeing that, somebody can come in with syncope, but if you don't have someone taking very good history taking, you might misdiagnose. And this really creates challenges for people and families if you're now having them have more medications and devices and things maybe they did not need. So we don't want to miss a diagnosis, but you don't also want to overdiagnose and have it be incorrect, and you're having people commit to things that they don't, really need and are going to be very impactful to their quality of life. So that brings us to the importance of centers that have expertise for LQT or multiple disease entities, that you have designated genetic arrhythmia programs that really are up to date, participate and are lead in clinical and scientific research to help advance our clinical guidelines and medical care. And a multidisciplinary team consisting of scientists, geneticists, counselors, electrophysiologists, administrators, because with anything you need the funding and the support to kind of move forward with these initiatives, APP staff, RN, and with the different device technologies, technicians that can really, take care of different kinds of monitors and things that we need and use to help diagnose long QT syndrome. And to be able to take a very adequate EKG and know that you're getting correct information when you're with the information that you're obtaining. So initially, evaluation and history taking are very vital in diagnosis and risk stratification of these patients. Also, family history is important in identifying other family members. If you had a family member that had a sudden death for unknown reason, or a history of deafness in the family, those are things that might lead us to long QT syndrome. And also a good review of what medications, because there are medications also that can prolong QT intervals, that the person might be more susceptible to that versus true long QT syndrome. So diagnosing a long QT carries many challenges from both medical and a psychological perspective. Sometimes there are those gray areas which can be very challenging for families to deal with, especially in the beginning, is when there was no genetic testing to get genotypes. We were going by, EKG and history taking them to make our primary diagnosis. So this has many challenges from the impact from the patient's in activity level and social aspects, and long-term surveillance of long QT patients with over a span of their lifetime, especially if a young woman was diagnosed initially in her teen years and now at childbearing years, those can have specific impacts to them. So as an APP, which is APPs are advanced practice providers, so nurse practitioners and PAs that work with our group. So we're involved along with the physicians in the initial evaluation process of history taking, meeting the patients, establishing some type of rapport, which is very important, long-term continuity of care, facilitating testing for not only the patient, but later on family members, interacting with other members of the team, coordinating testing and care, and then integrating information to formalize a specific care for that patient. And as things change, updating that care plan over time. A lot of the common questions that folks ask are, what are the common triggers? Treat or not treat if they're asymptomatic. What restrictions do they have on their activity level? And what type of medications can be used? Impact on family members. These are just a few of many questions that go through folks' mind when they're dealing with this. And again, this is a lifelong condition, so many things come up over time, and that's where the team is important in establishing a trust relation and just openness that you can feel comfortable talking to your provider. And I think that's one of the things that our team does very well. Some of the triggers are, again, genotype specific, long QT1, swimming, exercise, stress, long QT2, auditory and loud noises, women in the postpartum period. So those are some of the things, especially like loud noises, that we worked in the past with schools, that if they, a child had long QT2, you have fire alarms that go off, kind of creating a plan with them that this child is protective so that they not exposed to that and have an event, and just having those types of things and coordinating with families, schools, and so forth. Long QT3 can occur with inactivity or at rest. So in treating or not treating if asymptomatic, if a patient is genotype positive, definitely treating with beta blocker first line therapy is critical. And future therapy is dependent on the clinical presentation and ongoing clinical assessment, which can change over time in many families. But sometimes it's hard if, folks are, especially young people, it's very hard for them to commit to medication every day when they feel absolutely fine, when they feel that they're invincible. But the importance of treating with beta blockers cannot be expressed more and more. Recently, we had a family of channelopathy that the father was deceased, and two brothers. and one of the brothers did not take his medication and had sudden event and died. And that was very traumatic for the surviving brother, as well as now the implications for his children, which now he came to myself and my colleague Sonia, who have a very good relationship with him. So he's having testing of his children done, but that's the importance of having a good team that really patients can feel comfortable going to, and having a good rapport with people over time, because we have been with them for a very long period of time. The surviving brother I had known for probably 20 years. So this, it does make the team is very important in the delivery of care for these patients. Activity level. In the beginning, it was okay, only recreational activities as permitted. But again, as the time has gone on, more research is been developed. We can now say to people, if they are high athletic training, it really depends, and it can be discussed with their provider based on their genotype, based on their measurement of LQT. Just you can sit down and talk about things to make sure, are they going to be safe? And if they're not going to be safe, having that discussion with them that if you choose to do this, this is the possible consequence, so they can make their own informed decision as to how they wish to proceed. Because for some people that train at very high athletic levels, this is something that's important for their psychological well-being. So it's all about, risk and benefits and making those informed decisions together. There is, with many things, consensus statements as groups of experts get together, and there is a consensus statement that came out in 2015 regarding eligibility and disqualification recommendation for competitive athletes, which has been a helpful guideline. As far as medications, potential interactions between medications, that's something that we need to review. Some medications can prolong QT. So they might have to be, they have to be on it, the QTS be monitored closely. And just taking caution with prescribing prescriptions as well as over-the-counter medications. And for families, there's wonderful resources with Credible Meds, BrugadAdrugs.org that help to define some of those restrictions. The family impact can be astronomical, and we need to include everyone as far as EKG, genetic testing of all first-degree relatives. Sometimes folks can have a difference in that they might be positive for the gene, but then their QT level on EKG can be normal, and some genes are expressed differently, but still the treatment should be the same, with the primary treatment being a beta blocker therapy. And just the implications of future offspring, and what does that mean? And just like Maureen was expressing with her family member, there may be family members that don't want to get tested for whatever reason, and that certainly carries, other complications and just different feelings that can be very challenging over time. How do you convince your loved one that this is the right thing to do? But it's having families be as informed as they can and making their decisions to move forward with testing. But that can be a challenge for some folks because they might not want to, know, or they just don't feel that it's important for them to do. But then when something like that happens, when you lose a loved one, that's hard because of those guilt feelings that you feel like, could I have done more to make that person? But you can't always make people do what they don't want to do, and it's their decision. But that is a very difficult thing and very impactful for families. Does a negative test mean you don't have long QT? Not necessarily, because there are many gene mutations that may not have been identified. There's mutations of variants of unknown significance that, we kind of scratch our heads when we see that, because what does that mean? It might not mean anything right now, but in the future, as more genes and mutations are being developed, that could be an impact over time. But genetic testing is the key to identifying the genotype, and we want to make sure that it's done in a reputable, certified lab. As I said in the beginning, it was done as a research basis, and then it went to commercial labs, which initially presented some challenges as far as cost basis accessibility, whereas now it is much easier to access these labs and testing. A lot of them have their own folks that check into the insurance piece of it. So the families know upfront what is their out-of-pocket cost going to be, how much insurance it is going to cover, and how much they're going to cover. In the beginning, that was not the situation. It was always very challenging dealing with genetic testing, whereas now it is so much, the process is much more user-friendly and accessible for folks, which has been a huge plus in diagnosis and management. Other possible strategies, this was a study that came out of Italy of folks that had syncope on beta blocker with other testing or of the nerve, left cardiac sympathetic nerve denervation as a possible treatment for folks if they have syncope on beta blocker, as this is not a mainstay treatment, but this was a 50-year study done in Italy that showed that they had very good results with that treatment therapy, and thought moving forward that is a possibility for folks is to consider versus ICD. So what's the most protective therapy is to determine by genotype and have genotype specific management of the environment. Medication compliance is huge. Continued surveillance and ongoing follow-up care to ensure that you or your loved one is having the proper treatment over time and being managed. And if things are changing as folks mature, that these things that we're addressing and we're on the right track and having the most protective so that you can live the fullest life possible. So family resources, main is your healthcare team. Hopefully you feel comfortable asking questions and have good rapport that you are getting the care and information that you need. There are other resources such as the SADS Foundation that has a lot of teaching opportunities and information, and platforms such as this that offer a way for folks to connect and ask questions and get information as well regarding this very challenging diagnosis for patients and families. Thank you.
Thank you. It was very practical.